Welcome and thank you so much for being here tonight. My name is Ellie Zambrano and I'm a social worker and the Executive Director of the Center for Innovation in Social Work and Health. Thank you for joining us for tonight's event, COVID-19, Black Communities and Health Justice. Racialized social policies have created the conditions that make it hard for communities to thrive. Inequities in the COVID-19 pandemic have made this quite clear. Improving health equity calls for an acknowledgement of the ways in which white supremacy culture permeates health policies and practice at all levels, as well as taking collective action to develop systems that are led by anti-racist change. Tonight, our panel will explore the role of social work, healthcare, public health, community organizations, and policy that can play a role in advancing health equity. This event is hosted by the Center for Innovation in Social Work and Health here at Boston University School of Social Work and is part of our Health Equity Speaker Series. Our goal is to provoke thought and stimulate action consistent with the center's mission to expand the impact of social work and health and population health. We define health in broad terms, consistent with the World Health Organization, to include physical, mental, and social well-being, to involve work at the individual, family, community, institutional, and societal levels. Before we begin, I want to review a few housekeeping items. Each of our presenters will speak for about 10 minutes. Then after all of our panelists have presented, we'll have some time for audience questions. Please type your questions in the chat window in Zoom, and we will take as many as time will allow us. If you are a Massachusetts social worker needing continuing education credits for this event, you'll have received a link in your email confirmation to a quiz that you must complete to receive the education credits. We will also share this link in the chat. This event is being recorded and will be available on our website at www.ciswh.org. Let's begin with our first speaker. Linda Sprague Martinez, Ph.D., is Associate Professor and Chair of the Macro Department at Boston University School of Social Work. She's interested in examining asset-based strategies to tackle health inequities, such as community-engaged research approaches like community-based participatory research and youth-led participatory action research are central to her work. Having formerly worked in municipal and state governance, and as an adolescent mental health provider, she brings practical experience in community collaborations designed to engage diverse communities of color and low-income residents in community planning and intervention development. In 2017, she was a Boston Housing Authority Center for Community Engagement and Civil Rights Resident Empowerment Coalition Resident Empowerment Honoree. Thank you, Linda, for being here tonight.
Hi, thanks, Ellie, and thank you to the Center for inviting me this evening. I'm excited to be here with you. I'm going to talk, as Ellie mentioned, that the inequities we see are largely, in COVID, are largely the results of these broader inequities. And so I'm going to talk a little bit about health inequity broadly, and then white supremacy culture and how it operates to drive inequities, and then where can we as social work start as we move forward with this. So you can click to my next slide. So I already said what I was going to say. That's traditional. We say what we're going to say, then we say it. So you can click to my next slide. So just to get us in the same place in terms of language when we think about health inequities, sometimes you hear health inequities spoken about interchangeably with disparities, but there is a difference. Inequities are, disparities or inequalities imply that there's a difference between individuals or population groups, the state of being unequal, versus inequity, which really refers to differences that are unnecessary and avoidable, but in addition, they're also considered unjust and unfair. So, health inequities are those differences that we see in health outcomes that are unnecessary, avoidable, but in addition, also unfair in terms of and unjust in the ways in which they operate, which make them important to us as social workers because our priorities are advancing justice. So, you can click to the next slide. So when we think about inequities, we need to just remember, I have this like stop. We have to stop ourselves to remember that inequities are not bad choices. They're not about the fact that people aren't working hard enough. They're not about lifestyle decisions that are wrong. In fact, they're not about individual choices whatsoever. You can click to the next. I have an animation in here. Got a little creative. They're not about individual choices so much as they are the conditions within which the individuals operate. And so, when we think about every individual is part of a broader society or system. And so the systems that we operate within are they largely drive our health and our well-being. And so you can see from this slide that we know that socioeconomic factors are take into account about 40% of outcomes we see. And so when we think about the factors that really influence our health and well-being, we're thinking about, as we know from the World Health Organization definition of social determinants of health, the conditions in which people are born, grow, live, work, and age. And they're largely shaped by the distribution of money, power, and resources. And so we need to keep that in mind. You can click to the next slide. So Nancy Krieger from the Harvard School of Public Health talks a lot about embodiment and how we embody the environmental conditions, and talks about health inequities that we see are the embodied expressions of social inequities or inequalities. They're not just about individual bad choices, but they're really about things that aren't fair. So you can click to the next slide. And so, in order for us to really begin to think about this, we need to start to also think about health inequities. If they're the result of injustices, what are those injustices? And for us, they're really the result of structural racism, which is fueled by a culture of white supremacy. And then, if we're going to think further about, well, what is white supremacy culture, we need to really think about our political economy in the construction of race. And race, the construction of race was critical for justifying the racial hierarchy that we needed to drive our economy and to drive capitalism. It's dependent upon the racial hierarchy, and every sector of our society has pitched in to lend a hand in reproducing white supremacy culture to ensure its status as the dominant narrative. And no sector has not taken part in that. So it's really embedded within our broader societal culture. So you can click to the next slide. I'll show you a visual of how it kind of plays out. So this is for those of you who haven't seen this. It's an ecological model, but it's a different kind of an ecological model. It comes from the work of Schultz and Northbridge, who were focused on environmental health promotion when they created it. And the reason that I love this model is that it spells out quite clearly, and you can click. One time, I have way too many animations probably for a webinar. But you can see how ideology really drives how communities are shaped, right, in terms of our choices. Ideologies such as racism, white supremacy culture drive policy development, how we think about things, what we think is right, how we think the world operates. That drives because that drives policy and is embedded within policy. It begins to shape environments, as you can see in this model, and those environments are surrounded by a social context, which then in turn has implications for environmental conditions, stressors, all the way down across to individual outcomes when you think about health and well-being. So I really love this model. It's a little busy for a slide, I know, but it helps you to see how it is that ideology begins to seep into policies, seep into neighborhoods, seep into the conditions that impact individual health and well-being. So you can click to the next slide. And this reality is that um, the longer you're swimming in a culture, the more invisible it becomes. And so we don't necessarily talk about the fact that how it is that communities come to be the way they are. We just live and grow in them without understanding that those broader conditions. You know, if you think about it in social work education, yeah, you learn about redlining, you learn about the factors that contributed to the makeup of present day communities, but that's in your graduate degree. You know, oftentimes you're not learning about it. Maybe in college, if you studied American studies, maybe you're getting it there. But you're certainly not getting it earlier unless you had a high school teacher who was really excited about Howard Zinn and had you reading that history, but we're not getting the history. So we're living in these conditions, but we're not seeing it. And so that makes it really hard for us to recognize the ways in which we are influenced by white supremacy culture. And it makes it even harder for us to have these conversations because we get uncomfortable and we don't have oftentimes the language to really dig in. So you can click to the next slide. And so what happens is we start to, as we're looking, and this is a slide that I'd like to thank Elmer Freeman, who's also a social worker from the Center for Community Health Education Research and Service, who shared with me this slide many years ago, that as scientists, we're oftentimes looking for solutions and we're looking under the light. We're looking for what we need to, we're looking for answers to questions that we might have. But in doing so, we're ignoring these broader structural factors, whether it's poverty, whether it's racism, and in this case, thinking about white supremacy culture and how it operates to create the conditions in which we're studying, and so that we can't really we're looking at the light because it's the light is there, but we're not necessarily looking at the big picture factors that are the water, which we saw in the fishbowl, the culture that we're swimming in, that's creating the conditions. You can click to the next slide. And so I really love. I was very influenced by the work of Kamara Jones. She really did some amazing work in the early 2000s. At the time, I was working at the Office of Minority Health, but I'll never forget hearing her allegory of the gardener's tale when she talks about rocky soil. That if we have two plants and we're planting those, if we have two sets of seeds and we're planting one set of seed in rocky soil and one set of seeds in nutrient rich soil, that we're going to see different outcomes. And we have a choice at that point whether or not we want to say, wow, there's a difference. Look, this set of seeds is better than the first, and reallocate resources to the flowers that are doing well, or if we want to reallocate resources to the flowers in the rocky soil that maybe aren't doing as well. She really kind of lays out this argument for institutional racism, which she refers to it in the rocky soil, that we have two separate sets of conditions in our society in which people are living and growing, and then we have a choice at that point whether or not we are going to allocate resources or whether or not we're going to make judgments based on how folks are doing, and which in turn they may internalize. And so she talks about personally mediated racism as really the interactions between individuals, and then internalized racism is the ways in which we internalize those messages. And so it was so helpful for me as a young professional in thinking about racism and how it operates and really how it trickles down into the soil. And so when I think about solutions, I think oftentimes of how do we fertilize the soil? How do we actually redress the unintended or intended consequences of policies that led to conditions that don't allow communities to thrive, that don't allow communities to grow. So you can click to the next slide. Um, and so I've been thinking a lot about what do we need to do? Where do we begin in terms of communities? Well, first, we need to do our own work. We really need to understand how it is that white supremacy operates, how it is that sometimes we are complicit with white supremacy culture, sometimes how we internalize it on our own, how it impacts the way we interact across and within groups. And then we really need to start to fertilize the soil. There are ways that social workers can do that. I was thinking of this question: what is the role for social work? Social workers can partner with community organizations, activists, organizers. Sometimes they are activists and organizers, are macro social workers out there, supporting local initiatives and advocating for change. Really thinking about, there's been some great work here in Boston that's been done by Beck Mudd, thinking about changes. Maybe we need to change procurement processes within cities in terms of making sure that there are opportunities for Black-owned businesses to secure contracts. Maybe we need to think about equitable zoning within communities, school funding, government accountability, reallocating funds to community priorities, and really investing in this case, thinking about Black neighborhoods, Black people. How do we begin to redistribute funds that way within communities? Is one way we could think about it at community level intervention. And then there's, if you click to the next slide, what we can think about. Oh, here, actually, before I go to my next slide, I thought this was a very interesting quote. I spent this summer working with the Boston Public Health Commission, Boston Resiliency Recovery Collaborative, that's doing some great work. But really thinking about how do we engage community voices. And so I was working with them doing focus groups with young people on Zoom all summer long, thinking about priorities related to addressing substance use. And young people, and this quote is from a 16-year-old in a focus group who said, BPS, Boston Public Schools needs more funding. Left and right, I am seeing more expensive condos. Stop inviting more people into the city. Spend money for improving the schools, fund schools, invest in young people. And the answer to this was a recommendation that was made on how do we improve mental health and address substance use among young people. And so young people get it. They get these structural factors. I find it fascinating. They see what's happening in communities. And so the more that we can talk to people in communities, be working with young people, be working with adults in communities and informing our work, the more relevant the solutions are going to be. So you can click to my next slide. So thinking, we can also think about beyond work in the community. We can think about starting at home, thinking about our own organizations, right? Recognizing and naming the characteristics of white supremacy culture. It's not the job of people of color to solve these problems alone within our organizations, which often happens. But we can begin to think about ways we can build support within our organization to address the characteristics of white supremacy culture, which I have here on the slide from the work of Tema Oken. Talks a lot about characteristics of white supremacy culture: perfectionism, sense of urgency, outcomes, valuing outcomes over process, defensiveness, rigidity, praise in the written word, paternalism, power hoarding, fear of open conflict, valuing individualism as opposed to the collective good, objectivity, this idea that we have a right to comfort, and then more thinking progress is the equivalent of more as opposed to, that's that valuing quantity over quality, but really beginning to address how these values of white supremacy culture play out within our own organizations and thinking how we can build support and target them for change, and most importantly to act. And sometimes acting is small. I have this example here from my colleagues, Abigail at Southern Jamaica Plain Health Center, who often talks about the Trojan mouse, these little things we can do, experiments to begin to make change. And then on this last slide, I'll give you some examples of, you can click. So some of the ways, like examples for me, as a faculty member, what are some of the things that I'm doing or we're working on at home? And that's kind of beginning to think, and I'm in the macro department at the School of Social Work, and thinking about the ways we do business and as a department, and really honing in on our relationships, spending time seeing each other as colleagues, really centering relationships. And sometimes these practices can buffer against this idea of what is professional. It's not professional to kind of stop and get to know each other. But we need to remember that white supremacy culture is really about dividing people. It's about destroying relationships. It's about pitting communities against each other, and so that they are staying in line for the good of for the profit. And so really by us coming together, getting to know each other, valuing one another, having relationships, that's a direct act of resistance to white supremacy culture. We're also rethinking what and how we are teaching. I have my favorite Paulo Freire here on the slide for those of you who may know me. But Paulo Freire really challenged this idea of thinking about learners or students as empty vessels. He talked about the banking system of education, which happens in the Western world, where students are coming and we need to fill them up with knowledge. Well, the reality is that students are coming with knowledge. They're coming with experiences. They're coming with expertise. We need to work on how can we learn together, and really how can we learn from one another. And so thinking how it is we're teaching what we're teaching, and then the what is it that we're teaching. Oftentimes we think about we need to quickly focus on content, but we don't think about the how and what we're modeling. Sometimes when we are teaching in a top-down way, we're modeling for social workers to go out, and because we're training social workers to go out then and work in a top-down way. So we've been really spending a lot of time as a department thinking about how can we think about macro social work as anti-racist practice. How can we rethink the way we work together, the way we engage with students, and really having some hard conversations. I mean, it might sound easy because I'm talking about it fast, but this work is hard, and it's really about building trust and about among ourselves, and then with our students, and being authentic. And the same, I put being authentic in our community partnerships. I'm a community partnership researcher, but really spending that time on process, building relationships, and having those hard conversations. I have a doctoral student who I learn from every day we have a meeting that we have to really grapple with these difficult these difficult conversations about the ways in which power and authority operate within our relationships, and how that does harm for us and then for our community partners as well. So I could talk for days, but I'm going to stop because there's a whole panel. So you can click to the next slide. I put on the next slide some resources that we have available for those of you who are interested in doing the work. Don Belka Martinez, our Associate Dean for Equity and Inclusion at the school, has put together a number of resources with her team. So I thought I would put them up there if you want more reading on these topics, and then I will stop. Thank you.
Thank you so much, Linda. And I just want to remind everyone in the audience that if you have questions for our panelists after all four presenters complete, we will be doing a Q&A session for as many questions as time allows. So please put the questions in the Zoom chat. Thank you. So our next speaker is Dr. John Levy. He's a professor and chair of the Department of Environmental Health at Boston University School of Public Health and is affiliated with the BU Center for Anti-Racist Research. His research centers on urban environmental exposure and health risk modeling. He co-directs the Center for Research on Environmental and Social Stressors in Housing Across the Life Course, also known as CRESH, which involves interdisciplinary research activities connecting environmental epidemiology, exposure science, and health disparities modeling with the focus on the indoor environment and community engaged research. Current research also includes an examination of the social and environmental determinants of COVID-19 disparities in Massachusetts, research on the exposures and health risks associated with aviation, air pollution, and noise, a study using science methods to evaluate the benefits of housing interventions on pediatric asthma, and community engaged study to build response capacity to extreme health events in Chelsea and East Boston. Thank you, John.
All right, thank you, Ellie. I'll share my screen if I can find my slides. Okay, hopefully everyone can see that okay. So what I want to do is focus today on just briefly talking about data and some of the public health data that we've been utilizing and thinking about in the context of COVID-19 in Massachusetts. So what I want to do is really talk very briefly in my 10 minutes about three elements of data. The problem when we have no data, which for COVID was in the early period of the pandemic, though not exclusively. The problem when we have missing data, and missing data in this case on race ethnicity, and perhaps a much broader problem of insufficient data. What can we, if we've documented racial ethnic disparities, what can we actually do about it, and how can we use data to try to inform that process? So starting with the no data part of the story, it's hard, at least for me, to look back a year and think about where we were a year ago as the pandemic was just getting underway. But in those time periods of kind of late March, early April in Massachusetts, there was growing impact and growing concern, but very little data. I think people may not remember at this point that the state was actually not putting out data on what was happening on a city by city basis. They were only putting out county level data. And so a lot of hard hit communities were starting to feel the burden, but couldn't really get a sense of whether their perceptions were correct and whether the impacts truly were disproportionate. And so this is from an article about Chelsea, which was one of the hardest hit communities early in the pandemic, though the story is not exclusive to Chelsea. And so city leaders were demanding help, demanding support. In the absence of data, they were unfortunately not getting as much support as they truly deserved. Uh, Ellie mentioned that we have this Environmental Health Disparities Center. This works across Massachusetts, but has some local partnerships, including within Chelsea. So we had a lot of lines of communication there, and we're starting to talk to folks. And in particular, want to give credit to both Madeline Scammell at BU and some of her colleagues at Green Roots and the Chelsea Collaborative, who were drawing attention to this and starting to do some grassroots epidemiology and data collection, really wondering what was going on. Again, if you remember back in the early spring of 2020, New York City was really the epicenter of the pandemic, really hard hit, horrible burdens. And so they start to ask, well, how bad is it in Chelsea compared to New York City as kind of the benchmark of a hard hit community? And with some simple data collection and quick calculations we did kind of over iterating on email, figured out that on a per capita basis, Chelsea was worse than the hardest hit locations in New York City. Obviously, Chelsea is much smaller than New York City, but on a per capita basis, it was actually worse. But there were no data that could be shown to decision makers to really validate that. Again, the community voices were loud and clear on this point, and it should have been validated without data. But we wanted to get some information to push things forward. So again, there was nothing that existed at the state level at that time. The chiefs of police, it turned out, of a number of large communities, though, had data. They were gathering data on cases each day and sharing it on conference calls in the evening so they could coordinate their responses and understand what was going on. And so we were able to get data through the chiefs of police and gathered data from these communities and quickly plotted this out. This was work just over a day or so in April, and looked at the trends by community in Massachusetts. Again, not all of them, about 38 communities. And we compared that to some of the demographic attributes of the communities. The percent racial ethnic minority turned out to be far and away the strongest predictor of the trends in that first month. And you can see Chelsea indeed had the largest burden of any community, so the community concerns were validated. But this was not exclusively a Chelsea story. You can see up at the top of the list Brockton, Lawrence, Everett, Lynn, Malden, a number of communities that have large racial ethnic minority populations were hard hit in the pandemic. And this is no surprise. This is something obviously that manifests across a number of exposures and outcomes, but I think putting the data forward in that form and in such stark relief helped to draw some initial attention to the fact that, yes, it was happening here as well. But pivoting to the second category, as you start to get into the further need to understand what's happening in the pandemic, obviously, disease happens within communities, but it also happens to individuals. And we need to know on a case by case basis who is being affected to really characterize disparities. And to do that, you need to collect data on individual race, ethnicity as you get information on the cases. And basically, if you're missing some of that data, it's not a problem if it's random. If, say for 20% of the people you're missing the information and those people are the same as the people with data, that doesn't affect your disparities characterization. The problem is if some people are more or less likely to give that information, or some communities are more or less likely to give that information, or if it changes over time, you have a problem and you may be telling the wrong story about disparities in the pandemic. So we looked at these data in a partnership with Mass Department of Public Health. You can see I have on the top of this slide and a few others. These are preliminary results, not for broad distribution, but we did find a steady decline over time in how much race ethnicity data were missing. And so that was good news that as we started to move through the pandemic, this is in kind of the first wave, we were getting better at collecting those data, but the missingness was not random. In particular, looking on a community by community basis, race was more likely to be missing in lower income communities, lower educational attainment communities, and rural communities. Hispanic Latinx status, which was collected separately, was more likely to be missing in communities that had lower percentage Hispanic Latinx population. So This again has implications for how well we can understand the disparities if the data are missing differently in different places. And while we haven't looked at this formally in Massachusetts, this has been looked at elsewhere. This is from a paper that was just published this week looking in Fulton County, Georgia. And they actually did some modeling to say, with their missing race ethnicity data, what were the implications? And turned out they showed that disparities were underestimated by using complete case data, basically only the people who had reported race ethnicity. So you're understating by about 30% disparities for the Black population, about 60% disparities for the Hispanic Latinx population. So whether those numbers directly poured over to Massachusetts or elsewhere, hard to know. But I think what's clear is that not collecting these data in a systematic and rigorous way makes a huge difference. So the final thing I want to talk about is, perhaps again the most important element. Just saying that there are disparities doesn't really help us to advance solutions. So, these are unfortunately easily anticipated disparities given structural racism and its effects across so many sectors. We'd like to be able to know why and to be able to, in the short term, intervene. So this is from a paper published last year by a group out of Harvard looking at cases of COVID in Massachusetts for the first few months. And what they did was to try to see if any demographic or other socioeconomic variables explained the observed disparities. And what they found was for the Latinx population, if you included job type, household size, and foreign born non citizen status, that explained the disparity. So, not that these were necessarily the causal factors or the root causes, but it gives some hints that, for example, being an essential worker may matter, being in a crowded household and increased transmission in the household could matter. So these are factors that could be explored. Interestingly and perhaps disturbingly, none of the factors that they looked at could explain the disparities for the Black population. So those disparities remained unexplained, at least by the variables they had on hand. So we looked at this question as well in Massachusetts. This is a busy slide with a lot of data. For sake of time, I'll be brief, but this is looking at a multivariable model, so including a lot of different factors and looking at different time points in the pandemic. So looking April, or rather March through October in the pandemic, and seeing the association with different variables. So if you look in the center square here, percent essential services, this is the percent of the population that work in essential services. And this is a significant factor well above the dotted line, which is the line of significance across the whole pandemic. So if you have more essential workers in your population, you have more COVID, and that was happening throughout. Other factors varied over time. For example, this LTCF, that's long-term care facility beds, very strong early in the pandemic and less so later, kind of consistent with the horrendous burden in long-term care in older populations, especially in the first wave. If you look at the top, the variables for race ethnicity, you can see, at least in our analysis, the percent Hispanic Latinx was significant throughout the pandemic, even after you controlled for these other factors like essential services. The percent Black was also significant throughout after controlling for other factors, though the association was diminishing over time through the pandemic. So this again maybe gives us some clues about causal factors and things to explore for intervention. So just two more slides and I'll wrap up. In my mind, moving towards solutions, and maybe this ties back to the previous presentation, entails a look at social determinants and environmental determinants of health. And so we, through our Disparity Center, have constructed a database of a lot of social and environmental determinants. I've included a link to the website that has those materials now. This is everything that we have fully publicly available. And we're working with DPH to link the COVID data in the state with these social and environmental determinants so we could start to move upstream and truly understand, hopefully, some of the drivers of the disparities. So to wrap up, I think we need adequate collection of race ethnicity data to characterize disparities. This is necessary, but not sufficient, not even close to sufficient. Obviously, race ethnicity proxies for a number of structural factors related to historical and contemporary racism, and we need to both understand and confront those factors. Some of them are long-standing and challenging to dismantle. Others we can try to intervene on in the near term. and we need to do so to reduce the disparities and to reduce the overall burden of the pandemic. I think our evidence and other evidence keeps pointing toward a few key factors. They're not exclusive to these, but being an essential worker, being in a workplace where you can't be adequately protected from the virus, living in crowded housing, these are ultimately important factors regarding whether you are likely to be exposed, and if you're exposed, whether you're likely to transmit it to your family members. And so understanding those causes can help us intervene on the pandemic now and intervene more broadly on factors that can influence health and health disparities. So I'll stop there and happy to entertain questions and discuss later on.
Thank you, John. And again, just encouraging our audience to enter any questions that you may have in the Zoom chat, and we will go over questions after our panelists complete their presentations. And now we're going to move on to our next presenter. Dr. Cassandra Pierre is an assistant professor at Boston University School of Medicine, the medical director of public health programs, and the associate hospital epidemiologist at Boston Medical Center, and the chair of the Diversity and Inclusion Council. Supported by state and local public health agencies, the public health programs provide resources for HIV, HCV, and STI prevention in vulnerable populations. Her clinical interests include HIV management in special subpopulations. Thank you so much, Dr. Pierre, for being here today.
Thanks. It is wonderful to be here this evening with these wonderful panelists and at this great event. As an infectious disease doctor at a safety net essential hospital, it has been a really familiar process to look at healthcare decisions with a health equity focus, but this past year has been a whole other thing where it seems like every treatment and prevention recommendation related to COVID-19 that we've made has been about navigating social determinants of health and disparities in especially vulnerable populations, including and especially the Black community. So I would like to speak today about how this past year, despite the multiple warnings along the way, looking and recognizing the fact that COVID-19 is not experienced similarly across races or across different races when you think about outcomes, access, testing, treatment, and prevention. Despite all these signposts, these warnings, and the knowledge that we've accumulated and we've heard a little bit about over the past year, we continue to fall into these pitfalls of inequitable programs and policy that seem to perpetuate disparities in the Black community. I'd like to talk a little bit about Massachusetts COVID-19 vaccine rollout process in the Black community as an illustration of how, despite saying that we want to center our healthcare decisions, especially during this pandemic, in health equity, we often fail to be successful and to achieve equity. And then speak a little bit about how what actions we can use to promote and center equity in the Black community during the pandemic. This one and potentially ones to come in the future. So first, a review of COVID-19's impact in terms of numbers. So we have seen these numbers before, but just to kind of ground ourselves. So Black, Latinx, and Indigenous communities, as you know, are disproportionately affected for COVID-19 when it comes to infections, hospitalizations, and death.
So we see that there is almost 3 times higher risk of infection in our communities of color, as we've already heard a little bit about why that might be. We see almost a 5 times higher risk of hospitalization in these communities when compared to white communities. And in the Black community in particular, we see twice the amount of death as we do in white communities. And we know that this is not because of any genetic or physical or moral inferiority or luck or more susceptibility to poor COVID-19 outcomes in the Black and brown populations. As we've heard, it has to do with social determinants of health, household density, the neighborhood we live in, the kinds of jobs that we have, as well as their effect on chronic health conditions that predispose people in Black and brown communities to have more severe complications of COVID-19, but that's not the only part. That's not the only thing that's driving these differences. We know that systemic racism and racial bias in the medical system unfortunately exacerbates these already widening gaps. One example of this would be for COVID-19 testing. Thinking back to last year, which seems so long ago, we were mostly concerned about testing access at that time. And an evaluation of billing claims in February and March of last year showed that Black patients who were exhibiting classic COVID-19 symptoms were 6 times less likely to receive testing or treatment in comparison to white patients in the same healthcare systems who were exhibiting those symptoms. And we can say that social determinants of health had some part to play in this. Maybe there were differences in healthcare insurance, but it's really difficult to disentangle racial bias, most likely implicit racial bias in terms of who gets tested and who doesn't. And the disparities are also marked for COVID-19 treatment, and there's a long story there, but I've chosen to focus just on monoclonal antibodies, which are the only authorized outpatient treatment for COVID-19 that we have to this date. Because of previous concerns about equity in racial distribution of therapy for COVID, Massachusetts was primed to look at distribution of these medications through a lens of health equity, and dedicated 20% of the monoclonal antibody stock to individuals in structurally vulnerable populations where COVID-19 hotspots were located, so predominantly Black and Brown communities. That was on top of the other reserves. But despite the intention to ensure equitable access, what we actually saw and what the DPH reported last month was that 83% of the antibodies went to white people instead. 6% of the people who got the antibodies were Black and 6% were Hispanic and Latinx. So this is a marked disparity. We know who in our state, like the rest of the country, is more likely to get infected and who is more likely to be burdened by the severe complications of COVID-19. And that does not bear out in terms of who is getting the treatment. Why this disparity exists, as with everything, is complicated. We know that social determinants of health do factor into this. Our communities have more difficulty with accessing personal conveyances when it comes to going back and forth to these antibody infusion sites. We know that these antibody infusion sites are not really well situated in communities of color, that there is potential bias in treatment guidance and or enactment of that guidance. And there can also be the concern that Black communities are have concerns regarding the trustworthiness and safety of this new medication and the medical establishments that provide them, which is a narrative that we've been hearing very often in vaccines as well. That's a narrative that actually, unfortunately, may not serve us well. So as with every step along this process, we see racial disparities, of course, with COVID-19 vaccine rollout in the United States, with white Americans receiving a disproportionate percentage of vaccinations. And the explanation for this is primarily focused on vaccine hesitancy as the primary mover for disparities in vaccination among Black communities. But the actual story is more nuanced. And what we've seen with vaccine acceptance polls over the past few months is that there's been changes in them. So one that was recently published by the CBS News this week, or last week rather, showed us that among white adults, 26% had received at least one dose of the COVID vaccine, compared to 17% of Black adults and 11% of Hispanic and Latinx adults. But 31% of white adults said that they would definitely receive the vaccine, compared to 34% of Black adults and 41% of Hispanic and Latinx adults. So there is a disparity here. We see that communities of color, people of color, are actually willing to get this vaccine, but it doesn't match up to who is actually getting them. And so the actual reason for these disparities looks like, not surprising, access. It looks like an access issue. One example of that would be where the vaccine administration sites are located. The primary vaccine administration sites in this country, including in Massachusetts, are in healthcare systems. This is not to say that mass vaccination sites don't have their own equity issues, but most people get their vaccines from a healthcare institution, whether it be a clinic or a hospital. But we know that quality healthcare institutions are not as well represented in communities of color. And then that creates a vaccine desert where we are missing vaccine administration sites in predominantly Black and Latinx communities across the country, but predominantly in the South. A study that was done at the University of Pittsburgh School of Pharmacy last month showed that Black Americans in nearly 24 urban counties in and around Atlanta, New Orleans, and Dallas, among a host of other Midwestern and Southern cities, faced significantly longer driving distances to vaccine centers than white Americans. So again, what we're seeing is an access issue, and there's so many more issues with access in terms of schedules not being set up to allow essential workers to take time off from work to get their vaccines done. The scheduling process, which is predominantly online and excludes people who have a digital gap, who have no digital access or have a lack of digital literacy. So there's so many issues that with access that I think it is a disservice to really focus on the vaccine hesitancy story. So what are we seeing in Massachusetts? It may surprise you that Massachusetts, despite a very slow start, now ranks as third in the country in the percentage of Black people who have received at least one dose of a COVID-19 vaccine. But what it looks like actually, unfortunately, is that we're leading a losing pack. About 26% of white people have received at least one dose of the vaccine compared to 17% of Black people. And so this is a significant disparity. We may be doing better than others, but this is certainly a disparity, again, with who is both exposed to COVID and who is more likely to develop severe side effects from it. Despite the Massachusetts government emphasis on equitable vaccine distribution, which they've described as a pillar, health equity as a pillar of the vaccine distribution process in Massachusetts, none of the initial mass vaccination sites nor the first responder sites that were initially set up were located in areas with high social vulnerability that were within communities of color that were experiencing high COVID case rates. After a period of vocal activist outcry, the state did designate Reggie Lewis Center in the heart of Black Boston, Roxbury, as the third mass vaccination sites. And so we breathed a sigh of relief. But then we noticed the slots were being filled by an overwhelmingly white population from wealthy white neighborhoods in Massachusetts and even outside of Massachusetts, to the exclusion of Black and Brown people in those neighborhoods who are not as quick to fill up the slots. Another way that Massachusetts has attempted to try and to center equity in this process has been by designating 20% of the state's vaccine supply to hard-hit, largely structurally vulnerable Black and Brown communities, beginning in phase 2 of the vaccine rollout. Well, we've been in phase 2 for a few weeks now, and details on this are still scant and have not been nailed down. And activists are also now requesting more information about how the state is going to carry this off, how they're going to pull this off. So how the state actually has become third in the nation in terms of vaccinating Black people is largely through community efforts, really. Through community healthcare partnerships and community-led initiatives that seek to bridge inequities in our communities. So one example would be the Black Boston COVID-19 Coalition, which partnered with a Black physician group for a series of once monthly weekend events with physicians, nurses, pharmacists, and administrative staff of color in the Reggie Lewis Center. That has been incredibly well received. Boston Medical Center has also worked with faith leaders, activists, community health centers, and organizations to designate 5 community vaccine sites in areas that have been hardest hit in our communities, Mattapan, Dorchester, Rosendale, Hyde Park, and the South End. And many community health organizations have taken it, and centers have taken it upon themselves to design innovations that meet the needs of their community. For example, accessing mobile vans to deliver vaccines to homebound elders and other less mobile populations. So besides active engagement with community partnerships, other things that we can do to promote health equity during this pandemic and the ones to come include educating or designing education that resonates with Black communities and other structurally vulnerable communities. Translating the public health messaging linguistically and culturally into ways that are accessible to people. So people can conceivably understand, for example, how can you physically distance, quarantine, or isolate yourself in a multi-generational household where there are not enough rooms or bathrooms to do so. We've already heard about using data as a tool for equity. I think that we don't pay enough attention to attending to the social determinants of health, at least in our healthcare institutions. But there are ways to do that. Thinking about how we can link vaccine efforts with transportation to and from your appointment, making food pantry referrals at your vaccine sites and vice versa. There are a lot of ways to strengthen that. And then, of course, advocacy efforts to address COVID-19 disparities that we see, and that's across the spectrum of public health, healthcare, and social work. So in summary, I just want to say that the policies and norms that have led to Black and Brown communities bearing this disproportionate outcome for COVID-19 was not unexpected. It's not new, and we can't rely on those same policies and norms as the bedrock or a foundation for designing health equity outcomes. In order to enact cultural transformation, we really need new initiatives that meaningfully promote COVID-19 related health equity through focusing on social determinants of health and forming long-lasting and meaningful partnerships with the community organizations and advisors that are really our content experts. Thank you, and I look forward to answering questions in the Q&A portion.
Thank you so much, Dr. Pierre. I know we had a couple of hiccups in the beginning, but it really was informative, and thank you for your presentation. I'm having wonderful questions come through the chat, and I just want to continue to encourage people to put your questions into the Zoom chat as we'll go over them at the end. But we have one more panelist, and I'd like to welcome Denise Octavia Smith. Denise is the founding executive director of the National Association of Community Health Workers. As a community health worker and healthcare administration professional, Denise has designed and implemented community-centered strategies to achieve equitable, diverse, and inclusive partnerships, programs, and environments. Through her program development, research, advocacy, and collaborative partnerships, Mrs. Smith pursues a culture of health where individuals have self-determination and dignity, where communities meaningfully contribute to system design and governance, and where societies address structural barriers to well-being. Prior to joining the National Association of Community Health Workers, Mrs. Smith was the research associate and projects manager at the Yukon Health Disparities Institute, where she coordinated a statewide multi-sector coalition and alliance that developed research and community-level interventions to increase health insurance literacy, improve health system navigation in communities of color, and measure and respond to the neighborhood and racialized stress among young Black males. Mrs. Smith is also a Robert Wood Johnson Culture of Health Leader and a Universal Healthcare Foundation Leaders in Action Fellow. Thank you so much for being here.
You're welcome. Thanks for having me. I'll go ahead and share my slides. And thank you for the opportunity to share ways in which this virtual community can partner with Black CHWs in our communities during COVID-19. If this is the first time you are hearing about the National Association of Community Health Workers, welcome. We were launched in April 2019 as a member association uniting CHWs and allies across geography, across sector, across ethnicity to support our communities in achieving health, equity, and social justice. I want to take a moment before I get into the presentation proper to acknowledge my colleagues, my mentors, my peers, CHWs, some of whom you see on this slide, who have experienced profound loss, stress, anxiety, frustration during this now year and several months into the pandemic, as well as having very much hidden innovation and success in ensuring a racial equity and social justice lens to the work that they have continued to do throughout the pandemic. Whether they are distributing masks, driving people to their tests or their vaccine appointment, addressing social needs, helping people to enroll in the benefits through the CARES Act or more recent stimulus, helping people to return safely to work and to prevent infection and illness. There is so much to celebrate here. And I just want to acknowledge their fantastic work. So it is helpful for me to anchor this conversation by pulling way back, perhaps much further than most. Oftentimes you hear about community health workers as if we sort of appeared 50 or 60 years ago when we started to appear in literature. I would like for just a moment to acknowledge the forgotten healers. And often when I do this presentation, I speak about many different ethnicities and cultures and nationalities. But for this presentation, I will focus in on persons of African descent, particularly African Americans, brought to this country and enslaved, so that we can anchor the origin of community health worker work simultaneously in the integration of predominantly West African religious health beliefs and practices with indigenous Native American health practices, again, up and down the eastern seaboard and now the southern United States, with European medical practices, while we are also thinking about the environment that required CHWs not just to be sort of implementers of health practice and administrators of medicines and treatments, but also those who were concerned about advocating for, preserving, and advancing whole community health. That advocacy, that social justice, that sense of community well-being has not left the origins of our models. And so as we think about advancing racial equity and social justice, we want to look carefully at the opportunity to trust and center the origin of these models as we go forward and innovate. I love history, and so I also just want to take a quick moment. I do this often when I'm thinking about the arc of advancing health equity. Here, again, I'll focus on a few points across the history of enslaved Africans in the United States. And I'll start here. If you look at the bottom left of your slide, I mentioned this synthesis of diverse health practices from many different cultures and communities, and its purpose to heal, to prevent, and to protect communities that were enslaved. I often think about this 1899 study from W.E.B. Du Bois, and I think it's so critical because it makes me smile when we consider that talking about the social determinants of health is somehow new in our lingo over the last 20 years, that what concerns health, 80% of which actually happens outside of clinical practice or treatment or medication administration. But we know that story from this Philadelphia study. I often also jump to a very prominent and well-known group, the Black Panther Party, although they are more well-known for protecting communities or being armed, and less known for the over 60 survival programs that not only took root across the United States in Black communities, but profoundly impacted the coalition building, the advocacy in communities of many different races and ethnicities. Health clinics, free breakfast programs, sickle cell testing, helping seniors to safely, go to the bank and come home, addressing mold and asbestos in housing. So many different programs around survival, meaning that we're going to engage the community in addressing these downstream issues while simultaneously focusing on long-term and upstream transformation. We can also look to the 1985 report, Margaret Heckler's report that resulted in the foundation and the founding of the Office Minority Health. We can look to the 2011 report from the Robert Wood Johnson Foundation around healthcare's blind side. Again, reconciling the fact that primary care providers would love to address these other issues, up to 80% that impacts our health and well-being, but because of our models, our funding streams, and our current approaches and professionalism, we are limited in doing so. And so the big question is, will COVID-19 become a movement for equity as we innovate, as we bump up against barriers and try to overcome them? Is it going to be a moment for transformation? Well, CHWs have a critical role in this transformation. But I have to tell you that as of today, we are still very much a precarious workforce. We are disproportionately females of color. We are serving mostly through temporary grants and project-based funding that provide short-term relief, Band-Aids, if you will, to address the persistent and pervasive issues in marginalized communities. We are working in mostly under-resourced community-based organizations. The vast majority of us are not employees of hospitals or federally qualified health centers or health plans. And we are bridging across often siloed sectors that allow structural inequities to persist. The voice of one CHW that Nachwa connected with early in March, almost a year ago to the day of this pandemic. In these early days, CHWs, unfortunately, were not being integrated as we would have hoped, as later global actors and US actors would call for the strengthening of public health and a community-centered approach. But in the early months of the pandemic, these precarious workers, these workers who share the lived experience, the culture, the geography, the survivorship, the disease state of some of the most marginalized communities, had difficulty even getting a seat at the table to have their voices heard, to begin to support and strengthen public health response. I've had difficulty getting a response from the emergency response teams in my community. I've called, I've emailed the city, I've joined their Facebook groups, I've answered their questionnaires. It's very frustrating. And so there was a sort of business as usual going into communities and extracting data, asking communities to engage in a downstream way, to distribute a flyer, but not to help with the design and the development of an intervention. So Nachwa released one blog early in the month of May, and we continue to launch a campaign to help amplify CHW's roles during this pandemic. And so I'll sort of hasten to the second half of my presentation, which is, if you've heard me speak before, you've heard me say that on March 19th, 2020, the US Department of Homeland Security classified community health workers as essential critical infrastructure workers and recommended to states, tribes, and territories that they be paid to respond to COVID-19. But in those very same days, CHWs were being laid off by hospitals, by FQHCs. Doors were closing of many nonprofits, of course, because we were learning about the pandemic and how it spread, but also because these employers lacked sort of clarity in understanding CHW's leadership and capacity to respond in this pandemic time. It is critical also to lift up not just the leadership of individual CHWs, but to reconcile the fact that for several decades, CHWs have been organizing at the hyperlocal level, at the local and the state level, into networks and associations We saw disparity as well in the extent to which these community partners were brought in, integrated into pandemic planning and response, and funded to support that response effort. There are many different ways that CHWs can be integrated into COVID response, and I won't read the entire slide here, but what I want to do is sort of dispel this myth that we have limited capacity, that we are bound by certification and standards that other professions establish for us, and that we are not walking into the room with lived experience that can translate to profound innovation in the design, the development, the distribution, the evaluation of materials and strategies, that our lived experience helps us to address innovative coordination and administration of screenings and connectivity and navigation across silos and sectors, that we have deep understanding, often from our lived experience and those of our families, our neighbors, our communities, our faith-based brothers and sisters, on how to address technology, literacy, language, enrollment, transportation barriers, those that may be overlooked or not prioritized by other communities. And that in this moment, during the pandemic, we are sometimes as volunteers coordinating mobile testings. We are bringing people in our own vehicles to get vaccinated. We're organizing tables and helping people to register, addressing the gaps that elders are facing at this current time. We are helping to improve data collection by reminding people of the deep diversity and connectivity that we have to help inform those efforts. As well, we are remembering and lifting up those missing, silent, and sort of voiceless communities, those who are homebound, those who are houseless, those who are transient. It is time for us to make COVID-19 not just a moment, but a movement. And NACHWA has partnered with many organizations, you see their logos at the bottom, to say that we can really do this with a racial equity framework with an eye towards sustainability and transformation in the hiring of CHWs. And we know that the current administration has called for a significant scale up, and we see the RFPs coming. We see those opportunities coming for collaboration and contracting. Will we do this with a racial equity framework? Will we build in requirements to those opportunities and funding models? Will we invest in authentic CHWs? It is certainly the case that not everyone has trusting relationships with community, lived experience with community that allows us to bridge silos and sectors. So will we center authentic CHWs? Will we strengthen psychosocial connectivity in our services? I am hopeful but concerned that many of our vaccine efforts that are calling people out of their homes, out of their neighborhoods, out of their cities, are having people stand in line, and that hour or two is passing and we are not screening for mental health needs, for social service needs. Can some of this funding be leveraged to launch jobs programs to address the needs in public health infrastructure, but also the needs to strengthen a community-based infrastructure? Can we embed pipeline and careers programs and strengthen or braid our financing to sustain this workforce? So when you engage CHWs for this conversation, I'll say this is not only a workforce agenda, but it advances racial equity in the community. Certainly, NACHWA has partnered with Health Leads, Native Ways Federation, Visión y Compromiso, and many others to focus on ensuring racial equity in the development and distribution of a COVID-19 vaccine. And for time's sake, I'll just say that the slides are all hyperlinked. All of the pictures are hyperlinked so that you can look at the webinars, read the blogs, and visit a website that we've stood up, which is really a vaccine repository, helping community-based organizations and CHWs find the information information that they need to be able to bring that deep into community and strengthen community capacity. Finally, in February of this year, after a year's worth of planning and engagement of CHWs and our networks across the country, we have lifted up and we are sharing with public and private institutions a policy document to really help these institutions respect, protect, and partner with CHWs. It is very much the case that people are asking for CHWs to be on the front lines of COVID response, but they are not being paid a living wage. Not all of them, county to county and state to state, have access to PPE or to the vaccine. And there are many other ways to protect and partner with this workforce. So again, I invite you to visit that policy document and see if it might inform and strengthen your authentic partnership with CHWs and networks in your community. And thank you so much for your time.
Wow, thank you everyone for providing such a broad body of knowledge and expertise. We have an opportunity to answer some of our audience questions. We've received a lot of questions. I think it's really important that we all understand that the distribution of vaccines has been historically problematic, both domestically and globally. And COVID-19 exposed health equity gaps that already existed and have been long-standing in our communities. Some of the questions that we have, and I'll just go down and get through as many as we can. The first one is, how can the government ensure the safety and gain trust of the community, given the history within the community of the Tuskegee experiment, sterilizations of women in Puerto Rico, or slow response to non-white, non-heteronormative communities? What can we do to address these issues and work within our communities around these concerns early in this crisis and not any later?
Well, I'll jump in and just say, while health equity and social justice, the elimination of health disparities may be in the mission statements of many organizations, that does not mean, to Linda's point earlier, that this has translated to operationalizing equity and social justice. We are not going to accomplish everything in this time. I don't have those illusions, but we can certainly begin on the journey and develop indicators and hold one another accountable for that success. I think we can find that internally. I think we can find it through our COVID response task forces and teams. I think it can be embedded in some of the contracts and the opportunities for funding that are coming through this latest American Rescue Plan. So I think there are concrete ways that may indicate, to Jonathan's point, we know that when that 13 or 14% of the eligible US population being fully vaccinated, when those numbers are disaggregated, it's horrifying. And so we need to do a better job and begin holding folks accountable at all levels.
And I would just add to that, I 100% agree, to this point that Cassandra, you mentioned it in the context of your presentation about trustworthiness. Like, when the government is, how can the government be trustworthy? I think a lot of times we talk about the mistrust side, and I heard a great presenter a couple weeks ago from Boston Medical Center was talking about this idea of trustworthiness, but really being transparent as well, right? So being, accountable to the population, as Denise says, laying things out in contracts, rethinking, but to change the behavior, because I think we hear a lot of the language, especially in working with with nonprofit organizations as well as government organizations. We hear the language, but the behavior doesn't match the language at all. And so it's kind of like, I think of it as everything is parenting, because I'm a parent, and when my kids are saying something, but they're saying I'm sorry, but they're still hitting their brother, like that doesn't work. Like, you need to change the behavior. You can't keep doing the same things, operating the same way, and expect to see a different outcome. That's just, it's silly. So
I would also say, I think, one way, which, I don't think should be kind of I don't want it to be seen as performative, but we do have a significant gap in terms of racial disparities in healthcare workers, right? And we know that through this pandemic, we have called upon, I think there was a comment about people being called upon to be the vaccine spokesperson in their representative community, and whether that's fair or not. I have conflicting thoughts about that. We have relied on many people of color in science and healthcare and public health to bridge the gap in communication, to deliver messaging. And I think this is a good roadmap for future conversations. You know, there's a movement of by us, for us, in terms of trust. But that's certainly something that is also has been an equity issue as well, in terms of what we see in academia even, and representation and retention and recruitment and vitality of our faculty. I completely agree with data and making the data transparent. So when you're interrogating your outcomes, you know, as you're thinking through how to make, how are you going to win trust? How are you going to demonstrate your trustworthiness? You say, okay, this is where we're starting from, and we're committing, as everyone else has said, like, to actually doing the work. This is our data. We're putting it out there because we're intending to work on it and show you where we go to at intervals. And then I think the other thing that I think is important, but it's going to take some time, is reconciliation. Like, in addition to doing all the steps that we talk about, I know that many, you know, for many, Tuskegee and other things are remote. There are ongoing instances of medical bias that happen today in our institutions, in our systems. And I think it would be powerful to have our healthcare institutions admit or acknowledge that you know, bias, systemic racism has existed within their walls, and attempt reconciliation as a way of, as a first step.
Yeah, thank you for saying that. I think the sort of hesitancy and mistrust is a topic of discussion. I think there's also questions that we're receiving about what we're doing about confronting and dismantling these systemic issues. One question specifically was, what ethical duties does a larger university such as Boston University owe to the community in which it situates itself, in terms of providing concrete resources and leading with the state as itself being a vaccination site?
I think that's a great question. Could have a whole webinar on that. And what is the role of the university, right? What is the role of the university in paying into the local tax base? Are we paying, making payments in lieu of taxes? Are we paying full property taxes in our communities? I mean, that's a really big question when we look at infrastructure. You know I live in Roxbury, which is a neighborhood in Boston. It's not far from the university. I can walk there, but I certainly know that on a snowy day, I can walk there and walk through snowbanks because I can't move my car. But when I get there, there's no snow because of all the resources that our universities and institutions have that we don't have in the communities. And then I also know that, you know, there was a great spotlight article in the Globe a couple of years ago that looked at a number of issues, but one of them was around education and looking at the number, looking at the population of undergraduate students and students in universities in Boston, then looking at the Boston population and looking how few of our young people in the city end up in university. So, I mean, there's a lot we can do as an institution beyond COVID, but in the context of COVID as well. So I think that that's something that we really need to look at ourselves in terms of how we partner with communities. How do we contract? You know, Boston University has a number of RFPs and contracts that go out every year, I'm sure. Number of vendors that we work with. Are we working, what percent of our vendors are women-owned businesses, are minority-owned businesses, are Black businesses? That I would be curious. What percent of our contracts are Boston residents? I mean, all of those questions we can ask ourselves. There's a lot of work that has to be done, and I know that there are committees that were started in the context of COVID that are looking at our at Boston University policies. But I do think that there's a lot to look at. So.
Yeah, no, and building on that, I mean, I think there's the institutional level and there's also the individual level. And I think as, you know, researchers, if you're working in this space of public health or anything public health adjacent, I mean, I think you have an ethical and moral obligation not to just describe problems, but to try to help solve problems. And I think, we as academics are not good at doing that. Oftentimes we can write a paper and publish it, but don't do that last mile work. And I think that's where the community engagement and empowerment comes in, and having true authentic partnerships of the sort that Linda and Denise and others talked about, because that's really the mechanism to affect change. So I think we in universities can't do everything, and we shouldn't pretend that we can, but I think we can do what we're good at and establish those partnerships, and again, allow folks who are working on the ground and in the communities to take the information we have, provide information that is of relevance and timeliness, and then move that forward to drive policy.
Thank you. So a question that came through is, what can we do as an audience to help support communities of color in achieving healthcare access? Are there policies, bills we should be calling in to support on? Are there specific nonprofits that are fighting for this that we should donate or volunteer for?
Politics is not my realm, but I will say that there is obviously an ongoing conversation about Medicare, Medicaid-based reimbursements, and how communities of color are disproportionately covered by insurance carriers that have lower reimbursement rates, which means the quality of care might be lower, and also the reimbursements that go to the institutions that care for for the population that are covered by these insurance types have less resources and bandwidth to make meaningful change in their communities. So there's ongoing legislation and advocacy around that. And I think it's been revived this year with COVID-19. So that's one thing in terms of payer reform and Medicare versus Medicaid payment. And then that is, I don't know the likelihood of that changing, but that is a monolith. I think that would be a huge game changer in terms of allowing hospitals like Boston Medical Center that care for structurally vulnerable populations to be able to make meaningful changes in the lives of our patients.
And I would also say, add to that, I think to get out there and to be active, to get involved with coalitions and work that's happening, and to make phone calls. But I think first, getting out there, making relationships. There are existing coalitions in many communities. It was mentioned the Black Boston COVID coalition. Get involved with the coalitions, find out what the priorities are in local communities, and think about how you can advance the work that's happening in communities. Also, I think the important thing is, like, for all of us to do, is to just do the work and to understand really how the structural racism is playing out, how we are sometimes complicit in it as well. I think it's really important to do that reflective piece. I think a lot of times, um, this is all of our, it's right now we're thinking about the impact of COVID-19 inequities, but inequities impact all people. They don't just impact Black people. They impact white people too. They impact the ways in which we can work in partnership. They impact the ways in which we come together. So I think it's really important that we do that work as well, that interpersonal work and our own independent work.
And I think we have time for one more question. What links do any of the panelists make to the climate change impact and the increase of pandemics such as this, with all the racial and economic impact?
Yeah, I mean, so that's a big question for 657, but I'll say broadly, I mean, climate change is one of the other topics I work on, and there are stark racial disparities in the impacts of climate change as well, and those are felt now. I mean, if there's a heat wave this summer, who are the ones who have access to sufficient cooling at their homes or in cooling centers? And so, I think all of these are things we need to confront, and we need to, again, think about the structural factors connected to housing, the built environment, neighborhood assets, and so forth, that are important for climate change and were important for the COVID pandemic and are going to be important for the next thing that comes down the line. I think if we address these sort of structural factors of, where people, live, work, play, and pray, that will help in a lot of different dimensions.
I will also, although maybe not just tangential, I think obviously climate change, deforestation, we will be seeing more pandemics. We have seen an accelerated pathway. And what that means is that what we're addressing is actually in service of, unfortunately, the next pandemic. And that's, obviously this is going to be going on for some time. COVID will be going on for some time, and there is a real need to focus on it for its own sake. But we cannot let the gains that the realizations that we've made, that we've talked about on this panel, let them go, because not only do they undergird health for all of our communities, but will protect us and hopefully make the outcome of the next pandemic less predictable.
Well,
I think I'll add to this, since it's such a giant question, just to say, we need to be considering now and making a commitment now to build for the systems that we need for the future. We know that climate change is impacting immigration patterns. We know that there are concentrations of communities that are either in places where they cannot grow and sustain their own food. And simultaneously, there are now concentrations of people flooding cities that they can't really afford to live in. But it also has ramifications for the way in which we're going to respect the diversity of our neighbors, whomever they are and wherever they come from. We're going to have to make some big statements as to whether or not we consider access to healthcare coverage a human right, access to healthcare a human right. And when and if we say that, because that's a big statement, coupled with the statement that we are going to address and hope to prevent downstream chronic disease, this is going to be a radical shift. It will require a culturally relevant and respectful approach. It will require authentic community partnership. It will require a shift in where dollars go and who makes those decisions. And I just want to say, we've done this sort of thing before in small measure, but we've done it before. I think almost a couple of folks, I know Dr. Pierre mentioned her work in HIV. And I just want to say, we have glimmers of hope where we can center the voices of those most impacted, where we can bring coalitions together across silos and across sectors to address the whole health needs of individuals and families and communities. But this is going to be a big shift for us. So I hope we're all up for it. I know everyone on the call is, but I hope everyone that we touch and that we influence is up for it as well.
Thank you so much. Thank you, everyone, all of our panelists. We know how busy you are, and we appreciate sharing your valuable time with us tonight. I want to encourage the audience to get involved with these important issues. Thank you also to Nalaja McCoy for her leadership in organizing tonight's event, and to Michelle Walsh and her team in marketing and communications at BU, and the entire staff at the Center for Innovation in Social Work and Health. We hope that information from this panel can help you take some action in your work to advance health equity during this challenging time. Thank you and good night.